It's your weekly news in the EMS area, as well as some of my commentary, and part 2 of our segment on the physiology of pain. That's right, it's the MedicCast.
Transmitters? We don't need no stinking transmitters.
This is the MedicCast, a podcast for EMS providers by EMS providers, featuring EMS news, products, tips, tricks, and commentary. So grab your gear and glove up. Here's today's show with the Podmedic, Jamie Davis.
Well, good day and welcome to this week's episode of the MedicCast. I'm your host, Jamie Davis, the Podmedic, and I'd like to welcome all of you to the program this week. We've got a great show coming up for you with some, of course, our news segment coming up, also a little look at how you can get back in touch with me, some information coming up, and also part 2 of our segment on the physiology of pain, all coming up here in the MedicCast episode. I do want to remind you to head over and check out the MedicCast blog. That's mediccast.com/blog. You'll find a link to everything we discuss in this and every other episode there. So click the show notes link at the top of the page there and follow up on the resources and links and information provided here for this episode. And also check out the other resources and articles there and leave a comment on the site. Share back with the other listeners and readers at the MedicCast to see what's going on. Of course, you'll also notice there's a video version of the show there. So if you like to catch the MedicCast and live and in video, you can do so both on the website there. You can go also directly to mediccast.tv, and that'll take you right to the video versions of the show. And I would urge you also to check out the show on something like a set-top box, like the Roku box. If it's like $59. You can hook it up to your TV, internet connection, and you've got all the web TV you could use, including all the shows at the ProMed Network and the video version of the MedicCast, the nursing show, and a whole lot more. So if you'd like to check that out, I think it's a great resource and a great way to consume information comfortably in your living room, especially video shows like the MedicCast. So check it out. You can also get back in touch with me, podmedic@mac.com. I love to hear from you. And don't forget to call in on the voicemail line, 941-306-3342, 941-30-MEDIC. Not a lot of listener mail this week, so we're going to jump right on into this week's news segments. Again, send those emails in if you have any comments or anything to say about previous episodes. I'd love to hear from you, and I do return every email I get, so keep those emails coming. And without further ado, we'll get on into the news here in just a sec. We'll jump on into the news, and I want to start off with a look at a kind of shocking article, and you'll have to excuse the pun, you'll find out here in a second. A Cleveland EMT actually got jolted during a motor vehicle accident rescue when he was unaware that there were some live wires touching the car body, and when he ceased to become grounded when lifting the patient from the vehicle, he was blown quite a few feet away from the vehicle and didn't suffer any lasting injuries, but later found an entrance and exit wound from the jolt, and was eventually, of course, taken to the hospital to be checked out himself. Very lucky individual, and I think we all agree on that. But again, it comes back to the thing I say at the end of every episode. Scene safety, BSI, is not just the way I end my shows, folks. Scene safety is something you need to keep in mind, not just when you roll up to the scene as part of your initial assessment and scene size up, but also part of your ongoing sense of what's going on around you. And don't forget that there are inherent dangers all around us, especially in places like motor vehicle accident scenes, not just from fallen wires, although that was the case here. There is still traffic going by in many cases, and often there is an issue with sharp edges and other things that can cause injury or problems. So you need to really be aware of what's going on there. And luckily, no one was severely injured here, but it is something to just give us pause because this could have been a tragedy as an individual died, possibly from a shocking situation. Luckily, that did not happen, but I think what we should point out here is think about what would have happened to the care of the other patients in this situation had one of the providers fallen out, had one of the rescuers fallen out. This would have been a situation where everybody's attention would have left the patients to go and take care of their colleague and their comrade. And that's why we say we've really got to be careful. We have a double duty, not just to ourselves and our colleagues, but when we get injured, we don't pay attention to the patients as much anymore. And that's something that we all become distracted. That's not something we expect to happen. So we just get all off kilter about it. I think that it's a good thing to keep in mind and point out and make sure that you're taking care of doing the things you need to do to be aware of your surroundings, and be doubly sure if there's any wires or things down around a motor vehicle accident scene that everything has been de-energized and that the car is certainly de-energized. Don't assume just because people are working on the patients in the vehicle that they are not being shocked. This individual was being grounded by touching the vehicle and the patients in such a way that he was grounded. But however, the minute the patient came free of the car and he was still in contact with that car, he became energized, and the shock found a path through his body. So it's something to keep in mind, that just because it appears to be safe and everyone else is working, it's okay to ask the question, hey, those wires, has anyone checked those wires? Have we cut off power to those wires? These are questions that are not, it's not wrong to ask that even 10 minutes into the incident. Somebody may not have thought about it. Somebody may have assumed someone else did it. It's always good to go through your incident command structure and ask those types of questions when safety issues come up. That may have alleviated something like this happening. Some other alarming things going on. As continued budget cuts occur and people are cutting back more and more on what spending and resources are available, a lot of ambulance services, especially in rural areas, are driven very much by different types of taxes, property taxes in a lot of cases. And as the property tax rates have gone way down as the recession has hit and property values fell, so did the amount of reimbursement coming into these systems and services. That meant that several and many services that may have been just on the edge of staying open have had to close. And I've seen it time and again. There's a great article here coming out of newsok.com. It's from Oklahoma. Several Oklahoma rural ambulance services on the verge of collapse, and that they're getting ready to fall by the wayside. 60 ambulance services have gone out of business in Oklahoma in the past 10 years, many of them serving the most rural and remote areas, causing additional strain in resources of the other surrounding services as they try to pick up the slack. And this is something that places all around the country are facing, as maybe they have some kind of hybrid volunteer paid service or full volunteer service. The costs of running an ambulance, of maintaining and keeping an ambulance in the field, is still daunting to some of these places that just don't have the revenue, tax revenue, to support it. So I wonder what's going on in your area, because this is one of those things that isn't just happening in Oklahoma. It's happening in a lot of different places. And I'd love to hear back from you. This is one of those things where I think we become enriched by hearing back from the listeners in different parts of the country about what is being done on reducing costs, on cutting back. Everybody's cutting back. The increased costs of fuel, the increased costs of equipment and manpower, just everything is kind of conspiring to pinch the services provided by things like EMS, police and fire as well. What are you doing to pay for that and take care of that? Because a lot of EMS services are privately funded in some way through an organization that gets some grant funding or some kind of public support, but not in the way that police services do, for instance, where there's a clear funnel of income down a certain pathway to pay for police services in an area. That is not always the case in EMS, and certainly that's probably not the case in these situations. So check it out and let me know what's happening, what you've heard about or what you've seen in your area. Send me a link or send those things in. Again, we'd love to hear from you. Finally, in the midst of what's happening in Oklahoma, I found another article at chron.com. This is for the Houston Chronicles website. And they did a series on some concerns about Medicare and Medicaid fraud going on in some of the surrounding areas in the Houston area. And this has to do with the large numbers of private ambulance services and the large number of patients, so supposedly, according to the ambulance services, requiring transport by ambulance to and from doctor's appointments, regular care checkups, regular situations for a chronic illness, where they could be taking something that requires less cost, even a taxi or something like that, rather than paying for a full ambulance transport for a patient. And this is suspicions that there may be some kind of Medicare fraud going on here. Doesn't really go to say, but does say Medicare is looking into this and wants to know why there's so much medical necessity for this type of transport in the Houston area when they look at other parts of the country, similar metropolitan areas. They don't have the number of private ambulance services and the number of patients that are being transported this way, despite the same rules applying in those areas. Why has Houston got more people requiring this type of specialized transport for medical conditions? So there's a lot of things that raise questions here. And, this is one of those things that we need to be careful about. I'm going to say to you that if it turns out that you were encouraged to falsify documentation for medical necessity so that your company could bill for Medicare, guess what? You're guilty of that as well. You falsified patient records, and by doing so, you put your license in jeopardy as a medical professional. You put your ability to work in the healthcare field in jeopardy, because in some cases, Medicare will apply a penalty that says you can't work in healthcare anymore. That sounds severe, but basically Medicare's got the big stick. They're the ones that are paying the hospitals, the ambulance services, and the physicians' offices. And if they go out there and say you can no longer work for a service that bills Medicare, then guess what? No one can hire you. And I think that that's important to keep in mind. Your boss may put you in an awkward position and say, you have to fill it out this way because I say so. But if you fill out something knowing that there's not a medical necessity for this individual to be transported by ambulance, but you filled out the paperwork anyway, you're just as guilty. And it's been done time and again. We've seen physicians being charged for falsifying some of their Medicare records for patients, and the nurses and the office staff going down right next to them because they sat there and tacitly filled out the patient narratives and medical records falsely alongside, based on the doctor's recommendations and instructions, and despite the fact that they knew that it was not correct information. So don't fall into this trap, and I hope that you will keep this in mind when you work for a private ambulance. Look, I know it's hard, folks. You're in a position where you're going to lose your job, or you're going to take a chance, maybe or maybe not, you might get caught doing something illegal for Medicare fraud. I can't answer the question for you there, how you handle that specifically, but I can at least point out the danger you face by losing the ability to work anywhere. You could lose a job temporarily and go find a different service, a better service to work for that doesn't put you in that situation requiring you to break the law. So I just want you to be aware so that you can at least make a decision with your eyes open. And then if you get caught, and you made the decision to continue falsifying records, at least you would have been warned. I don't condone it, but I understand how difficult a position employers put their people in all the time by making them basically falsify things so they can bill inappropriately. And it doesn't excuse you, but it certainly puts you in a situation where I understand the forces at work encouraging you to do something you're not comfortable doing. So that's the news. I hope you'll check it out again over at mediccast.com/blog. And don't forget to get back in touch with me here. Send an email in if you have any comments on these articles and my comments on the articles. Send them in to podmedic@mac.com or call in on the voicemail line, 941-306-3342, 941-30-MEDIC. We're going to go ahead and get into part 2 of our segment on the physiology of pain management and looking at what goes on with pain. This is going to pick up with how we interpret and manage our pain and look at exactly how the way we handle pain management in the field affects the physiology of the patients a little bit. So you can get a better understanding of why it's important to be aggressive in pain management and to look at what you can and can't do within your protocols and maybe affect some change there if necessary to gain a better foothold and get ahead of the pain for your patients as you transport them to facilities. So we're going to talk about perception of pain now. And again, remember we talked about last week that moderating influence. If you haven't checked out last week's episode or our other segment on the physiology of pain, make sure you go back and do that. I think you're going to find that there's some good information there, and it leads directly into understanding how we perceive pain. many, many things affect how we perceive pain. Pain isn't just sent to like one place in the brain and makes a decision about it. It's being found, and more studies going on all the time, but it's being found that there are numerous areas, 4 or 5 different parts of the brain that are dealing with managing, moderating, and interpreting pain signals. And it's important to see that most of them are the subconscious level of the brain. They're in the brain stem and are really part of how we react to pain is built into our chemistry. We can't really control it consciously, and so we do patients a disservice when we think that they're just complaining about pain because they're complainers. There's a lot that goes on in pain management that is not conscious, and therefore that patient's pain is very real to them, and they are not just, they're not just complaining, and pain is personal to that individual. Don't assign your perceptions of pain to theirs. It's processed in the central nervous system, like I said, in 3 or 4 different places. Primarily, it seems in the medulla, the hypothalamus, and the cerebral cortex. And we can see how that would affect different aspects of the autonomic nervous system, just looking at the hypothalamus itself and how that affects different aspects of our endocrine systems and different moderating hormones in our body. The medulla as well. And then the cerebral cortex, certainly there is a conscious interpretation that goes along with pain, where our memories are, and that can have an effect too. If we have a very strong memory of pain, that strong memory, that strong sensory memory can come back to bite us in the butt later on, because we interpret our pain based on our previous experience in pain too. Again, I drew a picture here, a diagram, so if you're not looking at the video version, head over to the website at mediccast.com/blog or mediccast.tv. Find this episode and just fast forward to the middle portion where this segment is and look at this portion here. But I drew that same diagram, and this carrying it over into the brain's response. We have that pain impulse coming in some cases, if it's severe enough, a reflex response, motor response back to try to get away from the pain. And then the brain sends a modulating or moderating influence back down the system through the spinal cord and to the nociceptors. The nociceptive pain receptors are threshold-based devices. They have to have a certain amount of input before they transmit a signal. And that input is not just a set amount. It's not just written in stone. It can be modulated by return signals from the brain to say be more or less sensitive to the next pain response you get. And that can be moderated in several different ways by us through aggressive pain management, and several studies have pointed that out. So we have the modulation coming down, and again, it can be both inhibitory and it can be facilitatory. So it's important to understand that how we manage pain and how patients perceive pain are related to a complex series of events. And patients' past experiences, both subconscious and consciously, affect their future experience with pain, and how we manage their pain can affect both the current experience with pain and the future experience with pain the next time they have an injury or a problem. So pain management comes down to this. A lot of times we think of pain management, we think of analgesics. We think of those drugs out there. We have our NSAIDs, our opioids, our other medications like Tylenol. They're definitely our first line of defense in many cases for dealing with pain. I think it's certainly what people think about when they think pain management. It's important to notice some other things, especially for like injuries, sports injuries, soft tissue injuries. There's an acronym called RICE, and it's rest, ice, compression, and elevation. Often that can go a long way towards helping to alleviate pain and manage the patient's injury short-term and even long-term. So again, doing what you can to rest the injury. If a patient's got an injury, don't say, hey, well, come over here and walk to the ambulance, big rugby player guy. Tell them, hey, you know what? I want you to rest. I want you to hold that arm as still as possible, or we're not going to make you limp over to the ambulance on your injured leg. Let's put you on the stretcher and the stair chair and get you over there without bouncing you around, without making you put more injury on it. Ice, compression, elevation, all can be managed in the back of an ambulance with an ACE bandage, a flex wrap, putting an ice pack on the patient, elevating the extremity, all, and really you're trying to manage early inflammation here. That early inflammation puts additional pressure on the tissues, and that, again, think about it, that additional pressure is then picked up by those receptors and sent to the brain as, hey, it still hurts, it's even hurting worse because the pressure's worse. So we need to try to manage that early. And you can do it without just having pain management. So this is a BLS discussion as much as it's a paramedic discussion. And in fact, a lot of BLS services now are actually using Tylenol and some other analgesic over-the-counter kind of medications in the backs of ambulances for these types of pain management. It takes sometimes a half an hour for those medications to work, but again, just because you're not going to fix it in the back of your ambulance doesn't mean that you don't do the patient a service by having that pain management start to work soon after they get to the hospital. You also have distraction, and this is where, you know, a good conversationalist can be a benefit in the back of an ambulance. It is also the reason why it might make sense to, if in the right situation, have a family member ride in the back with you, not just always putting them up front. Sometimes you can engage them and get them to engage the patient in conversation to distract them from their injury. And this could be a lot of other things: massage, games, music, meditation, prayer, TV, internet, visitors. Are all these appropriate in the back of an ambulance? Not necessarily, but you know, the time is coming when, if you're a pediatric transport unit, I know pediatric transport ambulances, they'll have Game Boys in the back, or they'll, you know, I've done this. I've given a kid my iPhone to play a game on the iPhone, you know, to play Fruit Ninja or something like that. It's amazing how a child in pain completely forgets about their pain when they're playing a video game. Guess what? That works on adults too. You know, it's amazing how we don't understand that. So, you know, there are things you can do. It may not always be appropriate to meditate or pray with that patient, but, you know, if you've got a highly religious patient in the back of your ambulance and, you know, the time is right and you feel comfortable, there's nothing wrong with doing that. If that's, you know, if that helps the patient be at ease and you watch their blood pressure come down after you said a prayer with them, you know, that's the power of prayer, folks. It's about belief, and you have to you have to come to the patients where they are. So, you know, approach these things as you understand them, but don't be locked into, all I have is meds, and if the meds don't work, I'm screwed. There are lots of other ways to manage pain. It's also important to have a pain management strategy. What kind of pain are we dealing with? Is it acute or a chronic pain? What's the patient doing for a chronic pain? You know, if a patient has chronic pain, typically they're on some kind of medication for it. It may not be a specific pain medication. Arthritis patients often take anti-inflammatories that are not anti-inflammatory medications that alleviate pain specifically, but just relieve inflammation. So you need to know what the patient's done. What's worked in the past? This is one of those times when a chronic pain patient, you can say to them, hey, have you ever had this, has the pain ever gotten this bad before? What worked the last time? You know, they might say to you, hey, you know, the only thing that worked the last time was I went to the hospital and they were able to do a nerve block. You know, you can't do a nerve block in the ambulance, but guess what? That can be part of your report to the nurse. And you can even relay that to the doctor on the call. If you want to call in and get early pain management, you can say, hey, the patient's already talked to me. They were admitted last year with the same type of flare-up of their symptoms, and the only thing that worked was a nerve block. In the meantime, I'd like to try morphine. I'd like to administer morphine to them per protocol, and I'd like to have permission to administer up to 20 milligrams for this patient en route, and I'll call back if I think that we need more. You know, this is the kind of thing you need to be part of the proactive system and an advocate for your patient. What's causing the pain? Again, they do something, and this good history taking is important here. There's different types of pain. There's background pain. Background pain is pain that's just there. If they lay completely still and they still have pain, that's background pain. Nothing is changing it, it's just there. And this can be related often to inflammation and is just present at the site of an injury or the site of a medical problem, and this is what you're dealing with. Incidental pain has to do with something the patient does causes the pain. You know, when we ask OPQRST, well, we're asking, one of those questions says, is there anything you do that makes the pain worse or better? Guess what? That's part of this process, is incidental pain. And so you need to ask that question, and then you need to try to make sure that you're doing things in the way you position the patient and handle the patient to avoid causing that incident to happen again. Procedural pain is usually related to a specific procedure that we're doing. Guess what? When you start an IV on a patient, they're going to have procedural pain. You started an IV, stuck them with a needle, that causes pain. If you have a patient that's in a lot of pain, try to avoid doing things and procedures that cause them pain. If they have an injury, let's say they have a wound care issue and they've got a wound that's become infected, you may lift the dressing and look at that wound, but lifting the dressing on that patient causes a lot of pain. You know what? You don't need to look at that dressing again at all throughout that transport unless something drastic happens and they start bleeding out of that dressing and you need to do something like that. So avoid doing things procedurally that are going to make the pain worse unless it's part of your pain management, like getting an IV started. But certainly once you've done a basic assessment, if there's an assessment piece that caused pain and you don't specifically have to do that part of the assessment again, don't. Make a note of it so that if it ever comes up, why didn't you do this again in the ongoing assessment? You can say, you know what, when I went to palpate a pulse in their foot was crushed and I palpated a pulse and I didn't want to palpate the pulse in that location again. However, I did manage to check for capillary refill in the toes and I didn't want to palpate a pulse because of where the crush injury was. We have to be able to fit within the tool set we have, and we have to be able to innovate. And that's something that we're good at. We just have to innovate in other ways, and how we manage pain is one of them. Also, think about the resources that you have available. If you're a BLS unit, you may be able to use an ice pack and positioning to help that patient be comfortable, and maybe you cut their pain level in half, but it's not completely gone. Does it make sense to maybe rendezvous with an ALS unit for a patient in severe pain because of long transport to the hospital, and you can help them feel better? Again, long-term management of their pain is going to improve the way they heal from whatever injury or problem they have going on. So consider things like standing orders or other interventions that you can do to manage this pain, or other resources you might have available for this patient. So just keep those kinds of things in mind. Some care considerations as we wrap up this segment on pain management and physiology of pain. Let's think a little bit about pain care considerations. Pain is personal and individual. When we assess somebody's pain and we ask them that question, all right, now tell me what your pain level is on a scale of 1 to 10, on 1 being no pain or very little pain and 10 being the most pain you've ever had, can you tell me where you fall? If the person has a hangnail and they say they have the pain level of 8 and you've had a hangnail before and you thought it was only a 4, does that mean they're lying to you? No. Pain is personal, pain is individual, and you need to treat that person's pain as their pain. You need to remove yourself from the equation. Stop looking at them through your eyes and listen to them. That's why we assess the patient and ask them the questions. We don't ask the questions and then we go ahead and put our twist on it, in the back of our mind going, yeah, okay, 8. Sure, it's an 8. No, treat it as an 8. See if you can get it down to a 4, right? I mean, what's the harm? Putting an ice pack on a hangnail, is that going to kill you? And you're going to make that patient feel better, and that's, part of care. The word care, that's what we're supposed to provide for these patients. So keep that in mind. Aggressive pain management heals patients. Many studies now looking at how pain management, early and aggressive pain management of patients with surgical pain, with post-injury, traumatic injury pain, early management of the pain in the acute phases of pain have been shown to improve the patient's long-term healing. They heal faster and they have less complications at the other end. So we need to be part of that process. If we have a patient in pain, the faster we can start to manage their pain in the field, and as we transport them, the better the patient does long-term when they get to the hospital. And that may be for an ER stay, or it may be for an admission to the hospital. But either way, how we manage pain changes their outcomes and their healing process. That's been proven, and we need to make sure that we're part of the system that manages patients that way. make sure you keep in mind what resources you have available. If you have a burn patient and you know you only have 20 milligrams of morphine on board and you've got a 45-minute transport to the hospital, you don't have enough morphine, okay? Plain and simple. Anybody who's ever transported a patient with severe burns and you're trying to manage their burn pain, you don't have enough morphine on board if you only have your basic load. So this is where you need to think about, who else am I going to be passing through on the way? Do I need to have another ambulance from our system or another unit from our system rendezvous en route and dump off a load of narcotics to supplement what I have for the remainder of my transport? Think ahead and know what you might likely need. Especially with opioid pain medications, the patient, one dose doesn't fit all. A patient with very significant severe pain can take a huge dose of morphine and not have any significant side effects and still only reduce their pain slightly. Whereas you could give morphine to a person with very moderate pain and the same amount would kill them. Okay, so be cautious with how you manage pain, but keep your Narcan handy, but manage pain aggressively. And understand that the body grabs that morphine, grabs that opioid pain management medication and sucks it into the pain receptors, into the neurotransmitter sites, and grabs it and holds it and uses it up and grabs the next bunch to come around as quickly as it can use it based on the level of pain. So you can give a lot more morphine to a person in severe, earth-shattering, screaming at the walls pain than you can to a person with a more moderate pain. And yet you want to manage the pain, again, titrated to their level of pain. Transfer pain care information. If you did something that worked or didn't work, you need to let your next care provider know, whether that's a nurse, whether you're transferring to another EMS provider, you need to let them know, hey, this is what worked. Hey, I gave them 10 milligrams of morphine. I had orders for 20. The 10 really managed them. I gave it to them slowly over time. I also did this. I positioned them this way. I was able to put a pillow under this site and was able to put some ice on it. And the combination really got their pain level down to a 1 or a 2. The nurses need to know that, because guess who's going to be doing that stuff next? So pass that information on. It's vital. And remember that, I talk about nursing interventions a lot on the nursing show and my nursing side of things, but nursing interventions are typically those little things that nurses do to make somebody more comfortable. And those interventions can work in the EMS side as well. Raising or lowering the level of the cot may change the angle of their lower extremities to the point that the muscles don't pull the same way and their pain levels decrease. So try playing with those types of little tweaks along the route of your transport, and you might find that a 30-degree angle is painful, but a 45-degree angle isn't. Or they can't lay flat, but slightly elevated at the head seems to do something to stop the pulling in the abdominal space. All those things. Propping up the knees often alleviates some abdominal tension and pain. So whatever the case may be, those little interventions, and I call them nursing interventions because that's what nurses call them, but you can use them too. Pillows and ice packs, changing the temperature in the ambulance. If they're chilled and cold and shivering, those shivering motions are causing them additional pain and diverting resources from their own management of their pain. So be aware of just those little environmental things. Then educate your patients, educate yourself, your coworkers and staff about pain and about what you're doing for their pain. Talk to the patient. Again, ask the question, have you had this before? Have you ever broken anything before? The person with a broken ankle and you find out they broke their arm and for whatever reason it took a lot of pain management to deal with their pain, they could be one of those individuals who genetically is just predisposed to having high levels of pain because of how they interpret pain. You need to know that. So ask those questions. Educate yourself more about how pain works. You're listening to this, so that's half the battle, but there's some great resources out there, both here and in places like EMS World, the magazine and the site, gems.com and the magazine. All of those places have some great resources as well. And tap into your local hospitals. Like I said, they have pain management nurses in many cases, or even a pain management physician that has a practice. Ask them to come in and do some education for you and your staff about pain management. Utilize those resources and educate yourself about what's going on out there. I've got some references here that I picked up. There's some great resources. You know, the good thing nurses have is a lot of journals and research that go in and do different things. EMS, I'd like to see more of that. But these are two great nursing research articles on pain management and understanding acute wound care and gaining a better understanding, and also the physiology and processing of pain. Two great reference articles. And then I also have a link in the show notes to the Institute of Medicine report on pain management for you to check out. And that's a great thing to kind of download or make available to your supervisors, your medical director. Make them aware of what you know about and become a partner with them in trying to change the way you manage pain in your system. And that's going to wrap up this week's episode of the MedicCast. I want to remind all of you to get back in touch with me and check out the information available over at mediccast.com/blog. You'll also find information on how to sign up for our email newsletter, links to our Facebook fan page, and a whole bunch more links to resources and other materials you'll find over at the site. So check all of that out, available over there. Don't forget, we're also a proud member of the ProMed Network, available for you over at promednetwork.com. 45 shows over there and counting. We have a ton of resources available. I think 10 or 15 EMS programs over there just for you. So things like the EMS Garage with Chris Montera, the EMS Educast, Greg Fries. We've got Matt Fultz and Brad Buck over there with their show Standing Orders. So there's just a host of things over there. Jim Huffman's excellent program available over there, the EMS Office Hours. All available over at the ProMed Network site. So if you're looking for more things like the MedicCast and want to listen to some more things or watch some more things, check out the available resources over there, and all that's available over at promednetwork.com. Again, if you'd like to get back in touch with me, send those emails in to podmedic@mac.com or call in on the voicemail line 941-306-3342, 941-30-MEDIC, and I will get back to you. I love to hear from each and every one of you, and really want to get the pipeline rolling again as we've had the hiatus and the information coming from EMS World Expo have kind of not gotten the roll-in of emails that we usually get because of the different formats coming from the show. But we're back in the saddle with our standard format here, and so I urge you to share your comments about what you've heard in this episode. Don't just sit back and assume someone else is going to do it. I'd love to hear from you, especially on the voicemail line, so get in touch. You can follow me over on Facebook and Twitter under the handle Podmedic, and I look forward to hearing from you over there. Facebook.com/Podmedic or Twitter.com/Podmedic. And don't forget the MedicCast fan page on Facebook. Facebook.com/MedicCast. We've got like 2,500 fans over there and growing, and people leave links to different articles. They share comments on recent episodes and articles over at the MedicCast site right there on the Facebook fan page. So you can really have a great sense of community with some of the other MedicCast listeners and maybe meet some other folks in the MedicCast community that are on Facebook as well. So you can find all of that over at Facebook.com/MedicCast. Just click the like button at the top of the page and become a fan here of the MedicCast. That's it. We're going to go ahead and close out the show, and just remind you that we're going to continue to keep bringing these episodes out. I've got a whole host of new episode topics and things coming up through the end of the year, and we're going to have a lot coming up for you. So if you know some friends that might be interested in this and want to check it out, please show them how to do so. If you know how to subscribe via iTunes and somebody you know doesn't, show them how easy it is to subscribe to the show in iTunes or in some other service and get the show automatically sent to them. All of that you can do over on the website. There's links right there in the upper right-hand side to every type of subscription for the video, for the audio version, whatever you'd like. So check it out over at the MedicCast site at mediccast.com/blog. I'm Jamie Davis, the Podmedic. I'll be back soon with another episode coming up next Monday. In the meantime, I want to remind each and every one of you to please keep in mind, scene safety, BSI.